All right, well, thanks again for having me. My name is Aaron Macoskey, and I'm a physician assistant in cardiothoracic surgery at Lenox Hill Hospital in New York City. And today I'm going to talk a little bit about cardiothoracic surgery, some common cases you might run into, and give you an overview of what it would be like if you were a cardiothoracic surgery PA. So I know there's some understanding of what a PA does, along with the surgeon, and how we fit in with the team here. So that's what we'll be talking about today. A little background for myself. I decided I wanted to be a physician assistant back in high school. Luckily, I had some good guidance from my parents. They told me to write down 5 things on the piece of paper, and I should start shadowing them early. So junior year of high school, I started shadowing some different career paths, and they actually all were in medicine, and shadowed a couple of different fields. But what really interested me was physician assistant, specifically was watching a surgery in cardiac surgery, and that's what really caught my interest from a young age. So from there, I started researching physician assistant programs that I could get into as a high school student right out of graduation. And if I maintained a certain GPA, I could stay in through grad school as well. So the one that was the best fit for me was St. Francis University in Loretto, Pennsylvania, which is central PA. So I got in and did my undergraduate, received a bachelor's of health science there, and then continued on 2 years of graduate school and got my master's of physician assistant sciences from there as well. Right after college, I started working in cardiothoracic surgery with a group from Pittsburgh, Pennsylvania, that I had done a few rotations with as a student. So I think that's very beneficial if you can get your foot in the door any way possible for career opportunities while you're training and show your worth. So the first job, I was lucky enough to be hired, and we did a lot of bread and butter cardiac surgery. I learned a lot of anatomy, preoperative, intraoperative, and postoperative management of patients, and had some really great training after school, which, if you go into medicine, you'll find a lot of the learning occurs after you get out of school as well. So everything that you learn in school, you start to apply, and there's always more learning, even now today. So I was at Three Rivers Cardiac Institute for about 3 years, and then moved on to University of Pittsburgh Medical Center at the Presbyterian Hospital campus, and I worked there for about 5 years. And this was to further enhance my skill set within cardiac surgery. We were doing more difficult cases that you typically see at a university setting, a lot of heart failure, exposure to transplant surgery, and things like that. And I was there for 5 years and continued to enhance my skill set with understanding different disease processes and how to treat the patients at higher acuity, and worked with a lot of great people there. And then currently I'm at Lenox Hill Hospital for about the last 2 years, a little over 2 years, and work in cardiothoracic surgery here as well. So I knew I wanted to work in cardiothoracic surgery in high school, and now 11 years later, that's where I'm at still right now. To take a look ahead to the future, what I plan to do is I'm currently enrolled in the Strategic Healthcare Management MBA program here at Hofstra University in Long Island. So that's a look at what I'll be doing in the future. So I want to talk to you a little bit about what a typical day in the life for me would be. With cardiothoracic surgery physician assistants, our days start early. and change quickly and are constantly demanding. So I've worked in 3 different places throughout my career, and I've seen that to be consistent throughout each place. As a CT surgery PA, our roles and assignments can change from day to day, and it's very fluid. We can work in the operating room where we scrub into the surgery itself, and we have different responsibilities, and we assist the surgeon. We also work in the intensive care unit, specifically the cardiothoracic ICU. All of our patients go there before surgery if they're too sick, and certainly afterwards as well. And the physician assistant works alongside a critical care physician specialized in CT surgery and have a number of responsibilities, developing a plan of care for the patient for the day, making different diagnoses based on testing that we order, treating them with certain medications, and as well as procedures like chest tubes, central lines, arterial lines, things like that. We also are needed on the telemetry floor. This is where our patients go after surgery or before surgery when they don't require ICU care. They're still being monitored and still require specific care to a cardiothoracic surgery team. But we also work on that floor. Another responsibility as a CT surgery PA is working with consults for other services. So if the cardiology team needs our opinion to see if they need surgery, or the pulmonologist needs our input for lung cancer and things like that, then we can certainly receive consults throughout the day, go evaluate the patient, discuss it with the team, and come up with a plan moving forward. The PAs are also involved in the outpatient care, or what you probably think of as a regular doctor's office visit. So this is any new patient that we would see in consult, or post-operative patients, or patients we follow for 3, 6, 12-month appointments to follow certain things. So a PA is used in all of these different outlets in the world of CT surgery. Specifically for me, I work in the inpatient setting. So I typically work in the operating room, the ICU, the telemetry floor, or consults. I spend the most time in the operating room, and on the weekends, ICU or telemetry floor. So for our discussion purpose, I'm going to talk about a typical day in the operating room. And so I wake up and I get to the hospital at around 5:45 in the morning, and change into the scrubs. And by 6 o'clock in the morning, I arrive to the CT surgery floor. We have our operative cases scheduled for the day. I'll make a copy of that. Available to us, we have 3 ORs dedicated to the cardiac surgery service, and 1 to 2 operating rooms that are dedicated to thoracic surgery service. So throughout the day, there's many cases that are happening and that we're responsible for. And we get assigned to 1 room for the day. And so that room can have anywhere from 1 to 3 cases that day. So when I get there in the morning, I'll look at the case schedule. I'll look up the patients themselves, familiarize myself with the assignment, and make sure I know everything about the patient prior to starting. I'll walk through the ICU and make quick rounds on the patients that are there, specifically the ones that I operated on the day prior, to make sure that the night went okay and they're not having any issues. I'll look at the chest x-rays and review the lab work as well. So that all has to happen within 45 minutes because here on our service, 6:45 every day on the dot, we have morning report. And the morning report is a multidisciplinary team review of every patient on our service. We have every cardiac surgeon, thoracic surgeon, structural heart physician on our service in that room at that time, as well as nursing managers, case managers, and PAs that cover the floor. So at that time, we take every patient, discuss them at length, review their labs, chest x-rays, and other tests that they had, and come up with a plan for that day. That lasts for about a half an hour, and by 7:15, I arrive down in the operating room, and I go through the patient's chart to make sure that they have everything ready to go into the operating room. Do we have the consent? Does the patient have any other questions? Do they need me to talk to the family? Did they have the appropriate bath instructions from the floor the night before? And by 7:30, the patient goes in the operating room, ready to start the surgery. So for the next 45 minutes, there's a lot of preparation that goes into the surgery after the patient goes in the operating room. They have special IVs placed, monitoring devices, specifically arterial line placed in the radial artery, and central line placed in the internal jugular. That way we can deliver IV fluids and blood to the patient if they need at a high rate, and also monitor their blood pressure with the arterial line. Then the patient is sedated and intubated and put to sleep. They're positioned appropriately on the table, making sure that no pressure points are being stressed during the surgery, and they're giving a thorough prep to make sure that no infection happens during the surgery. And then we start the surgery around 8:15 to 8:30 a.m. And today I'll be talking about coronary artery bypass grafting, and that'll be the first case that I'll go in for the day. So coronary bypass grafting, or CABG, which you may have heard of before, is the surgical treatment of coronary disease. And what coronary disease is disease in the blood vessels that supply oxygenated blood to the heart muscle. And if you've heard of the term heart attack before, this is stress of the heart muscle due to coronary disease. We use arteries and veins to bypass the blocked arteries and restore blood flow to that cardiac muscle. The blockages are not removed, they're simply bypassed, as in the definition. So here's a picture of a heart, a cartoon, and there are three main arteries on the heart that supply blood to the muscle. There are variations to everyone's anatomy. If you did a heart catheterization on 10 different people, all would look different. But with the these three arteries within are all represented on everyone, however. You can see on the left side of the heart, which is the front here, the left main coronary artery is short segment. I'll go back one. That supplies the left anterior descending as well as the left circumflex artery. The left anterior descending comes down the front of the heart and supplies the front and the left side of the heart. The left circumflex coronary artery goes around the left side and the back of the heart. And the right coronary artery supplies the right side of the heart and down towards the base. So these are the three main coronary arteries of the heart. To start the surgery, we need to get into the heart. So we make an incision in the sternum. On this picture, the top of the screen is the head, the bottom is the feet. And then the patient is facing us, so the right side is on your left and the left side is on your right. We make an incision. If you can feel on your chest, the top of the sternum there where there's a little notch, down to the bottom of the xiphoid process on the sternal table. And then we dissect down through the fat tissue and the muscle and fascia, and then that's where we're met with the sternum. And sternum is separated with a sternal saw. Inside that is the pericardium, which holds the heart, and that's where we finally see the heart itself. And this is just a sternal retractor helping separate the chest. Now we need to bypass those blockages that we talked about. So how do we do that? We use arteries and veins, which we mentioned before, from the body. to bypass that. And so the surgeon always will dissect down what's called the left internal mammary artery, which is located under the breastbone. This is a picture right here of a retractor in the chest, lifting up the chest so we can see underneath the posterior sternum, and that's where the artery is. And we carefully dissect that from the chest wall, and we use that typically to bypass the left anterior descending artery, which is the artery on the front of the chest. We also use sometimes a artery from the arm. On the arm, there's two arteries that supply blood flow to the hand. On the thumb side is the radial artery, and on the pinky side is the ulnar artery. And we test the competency of those arteries prior to surgery. And if the hand can get good blood perfusion through just one of those, it's safe to take the radial artery. And so we do this nowadays by making a small incision in the wrist, as you can see on the second picture down on the left. And we take the artery out with a scope, as you can see on the bottom left picture. And as I mentioned on the prior slide, the left internal mammary artery is harvested by the surgeon. At the same time they're doing that, the physician assistant's harvesting the radial artery. So we do a lot in the cardiac surgery world in the operating room. The other way to take the radial artery is on the top right side, which is the open technique. This was the first way they took out the artery. It still is taken out that way in some centers. However, experienced PAs will use the endoscopic technique on the left, where you see how there's less of incision, less trauma to the skin, less recovery, discomfort, and numbness. But instead of a large incision from the wrist to the elbow, you're left with just a small 2-centimeter incision, as you can see in the bottom right hand corner. That's the incision after it's closed. So that radial artery is taking out entirely under the skin with the scope. It's disconnected at the wrist, and you simply bring it out through that small incision and disconnect it at the wrist level there as well. So that's a radial artery harvest. The other commonly used conduit for bypassing the blocked arteries is vein, and that comes from the leg. Everyone has a vein that runs down from the groin to the ankle on the inside of the leg, which is called the greater saphenous vein. And if we don't take a radial artery, or we need more than one conduit to bypass these blockages, we'll take the vein as well. Whenever coronary bypass grafting first started, like the radial artery harvesting, there would be a large incision from the groin to the ankle, and the vein would be taken out as an open approach. However, in this picture it explains, now the vein is also taken out with a scope, which is called endovascular technique. And on the right side, you'll see what we look at while we're harvesting the vein. The vein is the white object on the right side. We use this device to take the vein out and cut the branches that are holding the vein in place. Again, a lot less pain and discomfort and bleeding whenever you do it the endoscopic way rather than open, and quicker recovery for the patient after surgery. And again, the physician assistant takes the saphenous vein out of the leg while the surgeon is taking the mammary artery. So now that we have all of our conduit or tissue that we will bypass the arteries with, we have to talk about the surgery itself. So typically we do this surgery what's called on pump, or using the heart-lung machine, the cardiopulmonary bypass machine. For heart surgery, there's cannulas that are placed in the heart to help with oxygenating the blood and work as the heart and the lungs, because during heart surgery, typically you arrest the heart on purpose and stop it on purpose. That way we can work on the heart as it is stopped. While the heart and the lungs are off, this machine right here on the left, you can see, does all the work of circulating the blood in and out of the body and oxygenate it as the lungs are not working during the surgery. There's a big cannula that goes in the heart to remove the blood that does not have any oxygen in it. It goes through the pump, through an oxygenator, turns it into good blood, and then it's returned back into the patient and circulated throughout the body. So that's called on-pump surgery. And obviously, whenever the heart is stopped, it's easier to sew the anastomosis or sew that vein or artery onto the heart past the blockage to do the bypass grafting. In a CABG surgery, it's also possible to do the surgery off pump or without the use of the cardiopulmonary bypass machine. We use stabilizing retractor here. What you're looking at is the heart with a retractor in the chest. And then this machine is used to help stabilize the heart while it is still beating. So the benefits of not using the heart-lung machine is that there's less risk of blood transfusion, less risk of stroke, kidney failure, and respiratory failure. And so you may say, well, why don't we do all surgeries like that? However, this technique is very difficult. We're sewing very tiny vessels, around 2 millimeter vessel size to the artery or vein while the heart is moving. So if you can imagine that, it's very difficult. So you have to have a very experienced surgeon. If you're not an experienced surgeon, then it would prolong the intraoperative time and increase stress on the heart, which could set you up for an intraoperative heart attack or stroke. I'm lucky enough to work with a very talented surgeon here at Lenox Hill, Dr. Patel, and he does about 90 to 95% of his CABGs off pump. So it's really amazing to see. This is a picture of cartoon after we do the bypass grafting to have you understand what we mean by bypassing. So the red bypass there is the left internal mammary artery that the surgeon harvested, and it's separated from the chest wall and bypassed on the front of the heart there, like we talked about, to the left anterior descending. The blue graphs there are showing pictures of vein that we also use to bypass the blockages on the heart on the right side and the left side distribution. And we sew it onto the aorta, so every time the blood is pumped through the heart, the good blood goes through the aorta, down these bypass grafts, and supplies blood to the heart muscle past the blockage that was prevented before. So that's what CABG looks like. So this surgery itself takes about 3 to 5 hours, maybe longer. The chest itself is closed with stainless steel wires that stay in the patient forever. It does not bother the patient, and they won't know anything about those wires unless they would get a chest x-ray and be able to see that from there. They're made up of a stainless steel that the patient will not go off in a metal detector later in life, and they are MRI compatible. And then the skin itself is closed with dissolving sutures. And so at the end of the day, the patient will just be left with a line down the chest to make it look nice for later in life. With cardiac surgery patients, specifically open heart, they recover directly to the ICU. It's not like an appendix or gallbladder surgery where the patient has a breathing tube taken out immediately. The patient wakes up on the operating room table and they recover in the recovery room. These patients, because we typically stop the heart, we worked on the heart. It's a very critical procedure. They are left intubated and sleeping on purpose and taken straight up to the ICU. And then the patient remains asleep with the breathing tube in the ICU until everything, we are satisfied with the labs, chest x-ray, and gas exchange before we start to wean the sedation and work on getting the breathing tube out. So at this point, we just finished the CABG surgery. The PA stays with the patient until they arrive in the ICU. So I will help transport the patient from the operating room table onto the bed and then up to the ICU. I'll sign the patient out to the ICU PA, explaining what surgery we did, a brief history on the patient and what to expect, and then follow up on the immediate post-operative labs that we sent and chest x-ray. So on this particular patient, we got the x-ray, and it seems that the patient has a right-sided pneumothorax, which is a collapse in the lung. This could happen after surgery for a number of reasons, but most commonly, we had just opened the chest, and we might have opened the right pleural space, and the chest tubes that we leave in may not be communicating directly with that, so the lung is not fully expanded. We need to help expand that lung because the patient will have problems weaning from the ventilator. So that's another responsibility that I'll have to do before I can move on to the rest of my day. So we have to get all the supplies, place a chest tube in the patient in the ICU at bedside, check another chest x-ray to make sure the lung is fully expanded, and then you're done. A little picture on what the pneumothorax would look like. So on the left-sided picture, you can see the lung is collapsed because there's communication with air outside of that pleural space. So we need to place a chest tube. Chest tube goes in between the rib spaces at the bedside. Once the chest tube is in the appropriate place and it's hooked up to a chest tube canister, the lung will fully expand, and we'll check a chest x-ray to make sure that's happened. So even whenever you're done with the surgery, nothing is completely done until you make sure the patient's okay in the ICU. So at that point, it's probably around noon or 1 o'clock. Might think it's time for lunch. However, I just got a call from the PA that's on consults today, and they said, hey, cardiology just called us and said they just did a pacemaker on somebody a couple hours ago, and they initially were doing fine. However, all of a sudden, patient's not doing too well. Blood pressure is a little low, the heart rate is a little fast, and the patient's just not acting right from a mental standpoint. We need to go check this out. They did a immediate bedside echocardiogram. An echocardiogram is an ultrasound of the heart, which shows the heart chambers, the valves, and the pericardium. And on this particular patient, we found that there's a large pericardial effusion. So the sac that holds the heart has a normal physiologic amount of fluid that works as lubrication as the heart squeezes. However, if there's bleeding or other reasons for the fluid to build up in that space, if you can think of a small space and the heart is beating in it, if there's a lot of fluid and that fills up that space, the heart won't beat as well. And so what that'll leave you with is low blood pressure, which is not good. The heart will try to compensate by beating faster, which is not good. And you'll start to go in this downward spiral where the heart is not perfusing the rest of the body well. So this is a surgical emergency and what's called cardiac tamponade. And we need to do something immediately to fix that. So as I said, cardiac surgery team was called, and we did the echocardiogram, which confirmed that there's a large effusion or fluid around the heart that needs to be evacuated. So we, as PAs, we get everything ready to go to the operating room as fast as possible. If possible, we talk to the patient about the procedure itself. We consent the patient. We talk to the family. We can even, if it's an emergency, we even wheel the patient ourselves to the operating room as fast as possible to get this problem fixed. Here's a little slide on what a pericardial effusion can look like. Again, on the left, this is the sac surrounding the heart, and this is fluid developing around the heart. The membrane, the pericardium is a membrane itself, so it is elastic and changes size. However, at one point, there is not enough space to accommodate both. So that's whenever the patient gets sick and requires intervention by us. So treatment is you got to get that fluid out. And there's a couple of ways to do that from our standpoint. So either way, they have to get taken to the OR. And the first way they can do that is what's called a pericardiocentesis. We remove the fluid with a needle and you leave a drain in there in that pericardial space for further drainage. This is a less invasive way and the preferred method if it's able to do it that way. The other option is a what's called a pericardial window subxiphoid approach, which is below the chest itself, below the xiphoid. If you feel in the sternum, we make about a 2 to 3 inch incision, open up that pericardial sac itself, and drain the fluid out, and do that surgically. We also leave a drain in place there as well for further drainage. When it comes to which way the fluid is evacuated, we always try to do it from a pericardiocentesis standpoint first. If it doesn't look like we can do that, then we'll move on to a subxiphoid approach. Here are a couple pictures of those things. So on the left side is a pericardiocentesis where you use a needle and ultrasound, typically the echocardiogram, and we guide our needle into the pericardium while aspirating fluid out. Once we aspirate enough fluid off to alleviate the tension on the heart itself and we see the hemodynamics get better, then we slip a drain in there, which you can see on the patient's on the picture on the top right. And that drain will stay for several days to make sure that the fluid does not reaccumulate and need any further surgical intervention. On the bottom pictures, this is a pericardial window where right below the sternum, we make the incision like we talked about. And on the right side, you can see how we're opening the pericardium and draining that manually. And again, a drain is left in there as well to monitor any further drainage and to make sure that it's not reoccurring before we take it out and send the patient home. So either method takes around, anywhere from 1 to 3 hours. So again, the physician assistant is helping throughout this whole process, the surgeon that's doing so. And again, in this particular patient, we evacuated the fluid with the needle pericardiocentesis, and we transferred the patient to ICU after the procedure for close monitoring. Again, we signed out the patient to the ICU physician assistant. And by this point, it's probably, 4 or 5 o'clock. You've been on the go all day, not much downtime to sit down and do other things. So, is my day over? Depends. As surgical physician assistants in cardiac surgery, just like the surgeon, we also take operative call as well. As we said, every physician is accompanied by a physician assistant for these cardiac surgery cases or thoracic surgery cases. So if there's surgeries going on past the normal workday, then we need to stay with them to help finish these remaining cases. So you have to be very dynamic with what you know how to do and what you're comfortable with in the operating room, because you can change from a CABG like we talked about in the morning to putting in an emergent chest tube afterwards, being called to an emergency pericardiocentesis, and then maybe the late case that day is a thoracic surgery where we're removing a lobe of the lung for lung cancer. So then you're now doing some thoracic surgery. So you have to be able to be comfortable with all that and very dynamic. But it's, if you like medicine and you like surgery and anatomy, it's a really amazing profession. So in this case, a thoracic surgery case is still going on. So I would go up because I'm on call and have to stay late that day. Would relieve the PA that was assigned to the thoracic room that day. I let them go home and I'll finish and stay as long as it takes to finish that case for the day. So at that day, the last is that particular day was 8:30 at night. The last case was finished. Transport the patient just as I did earlier in the day. Sign it out to the nighttime physician assistant. And before I go home, I'll still review the cases that are on for the next day and make sure that all the patients have everything they need to start those cases and make sure all the appropriate orders are in. Another thing that goes into the play with taking call is that even though I finish all the cases, I'm the last one there for the day. I can go home. However, I have to be available in the event any emergency would come in through the night to come back into the hospital. And there are a variety of different surgical emergencies in the world of cardiothoracic surgery, whether it's a dissection, which I think one of my colleagues spoke about at an earlier lecture, to a emergent open heart surgery cabbage for a patient having a heart attack that can't be fixed with stenting, to some thoracic emergencies as well. So at that time, I would go home and the on-call physician assistant would be responsible for any emergency cases occurring overnight. So we live close to the hospital, have about a half an hour time window where they would like us to be able to respond to the hospital in the event any emergency would come. So that's the end of my slideshow here. You guys can jot down my email if you have any questions you'd like to add after all this later, if you'd like to reach out to me and be able to open up to some questions now.
So I just opened up the chat if you want to stop screen sharing and take a look there.
Sure, do that now. All right. Okay. So I'll put my email in. I'll bring up my email again. Sorry, some people are asking for it.
I can send it to the chat if you want to just answer the questions now.
Sure. All right. How do you learn EVH? So EVH, or endovascular vein harvesting, is a process that takes a while to become proficient in. The way I learned it was I was sent to the Cleveland Clinic, and they did a seminar on teaching you how to take the vein out with a cadaver. And after you learned the basic skill set there, I was accompanied on my first job by a senior physician assistant, and they would scrub with me and walk me through the whole process. So that, it takes, everyone's different, but it takes, probably 6 months to get better at that. And same goes for the radial artery harvest. I went to Cleveland Clinic for that too. And they did practicing on cadavers, and same thing, a lot of support from the senior members of your team, other physician assistants, where they scrub the cases with you and provide a lot of support. That way, you're not too intimidated while this all starts. Did you do a specific CT surgery clinical and PA school? Yes, I did. I did actually 2 electives in CT surgery and 1 actually in intensive care because I knew I wanted to do that type of medicine and thought ICU experience would be important as well. Go back up to some of these earlier questions. How do you balance your career with your personal life? Being a PA seems very demanding. That's actually, so whenever I first wanted to get into medicine, I had some people I talked to who were physician assistants and physicians, and work-life balance is important to me. And I think that's one of the reasons why I chose to be a PA rather than a physician, because a cardiac surgeon is a very demanding profession, and the team of PAs supporting is quite large, whereas, you know, you might not have as many physicians. So, you know, typically I take call 1 day a week, 1 weekend a month. So if you're not on call, you're typically at the hospital from 6 a.m. to 5 p.m. And then once you go home, you're not required to be called on by the hospital anymore. So there is a good balance there. Every program is different, but in the 3 that I've worked in, it's all about the same, where you take call once a week and 1 weekend a month, but it can vary. What happens if there's a second heart attack? What arteries do you use for the second bypass? That's a good question, because you can do a really good job and do an open heart surgery on a patient, but if they don't take care of themselves, they go back to smoking, not eating healthy, not exercising, uncontrolled diabetes and things like that, the bypasses will not stay open. Arteries, like the left internal mammary artery, stay open longer than veins. And so veins typically go down first. And so whenever that happens, you have to do another heart catheterization to identify the anatomy and see what your options are. It is possible to regraft farther on that coronary artery past the blockage. However, sometimes you can't bypass, and they may need to be stented at that time. If the arteries or veins are not fully blocked, then sometimes those bypasses that we did can be stented by the cardiology team as well. How much cardioplegia do you use to stop the heart? That depends on from surgeon to surgeon preference, but usually at least 1 liter of cardioplegia we use to stop the heart initially, and then we'll redose as we continue to work on the heart, depending on how long the surgery is, and also depending on what type of cardioplegia you use. That might be a whole other lecture in itself, but there is different cardioplegia, which is a solution used to stop the heart. And some of it you need to dose in intervals quicker than others. But initially, dose is usually about 1 liter of cardioplegia, and you'll see the heart stop beating. Why the radial artery and not the ulnar artery? That is because of the caliber size of the radial artery is larger. So when we bypass it on the heart, you're going to be able to have a better conduit for bypassing that artery. How do you establish whether on pump versus off pump is better for the patient? Really, that depends on the skill set of the surgeon. If the skill set of the surgeon is to perform off pump surgeries and they do a really technically excellent job, then we'll do the surgery off pump. However, if that's the surgeon was trained to do it with the heart-lung machine, then we'll do it that way. There's a variety of factors that can prevent you from doing the surgery on pump. Whenever we do these surgeries on pump, we have to cross clamp the aorta and isolate the heart itself. So if there's a lot of calcium on that aorta, we don't want to cross clamp it because it could cause a stroke, piece of that calcium breaking off and going to the brain. So that's where a lot of analysis of the patient is important prior to surgery and operating, that you identify that beforehand. Go back up to the top here. All right. So what is the difference between a double bypass and a triple bypass? So that all depends on how many bypasses you're doing. So if you heard of cabbage times 1, cabbage times 2, cabbage times 3, or double bypass, triple bypass, quadruple bypass. So that means you're bypassing, that all determines how many arteries you're bypassing, how many blocked arteries. So if there's 2 blockages that need bypassed, that's a double bypass. If there's 3 blockages that need bypass, that's a triple bypass. Does a typical PA have hours that are as crazy as yours? Every specialty is different. And like I said, not every day is crazy. You know, we have busy days and we have not so busy days. As a PA, working in the operating room, we work 4 days a week. So you already have 1 day off during the week. And your days are 9.5-hour days where you typically work from 6 a.m. to about 4:35 p.m. And like I said, if you're on call, you work later than that. But on the days that you're not on call, I think it's a pretty reasonable lifestyle where you can still go to the gym after work or find some activities that you enjoy, as well as spend time with family and friends. Cardiac tamponade is any type of fluid that is in the pericardial sac that's compressing the heart. It can be blood. It can be sometimes patients with certain cancers can develop cardiac tamponade, where there's hemorrhagic effusion around the heart, and some different disease processes and infections can cause it too. You know, lupus and things like that can cause normal body fluid to build up at a higher rate than normal. Is there ever a situation where non-absorbable sutures are used under the skin? There are situations where we need to use non-absorbable sutures above the skin that are removed later, but under the skin, we always use dissolving sutures. That way, there's less risk of infection under the skin. And situations where we'd need to use non-absorbable suture, that would be on the more obese patients, where we're worried about the tension of the chest separating after surgery as they start to become more active. We may place retention sutures to add more stability. Get down to some more questions here. Pericardium is very thin, so how difficult it is to stitch it back together after draining the fluid from a pericardial window. Actually, the pericardium doesn't always have to be closed. Even with the open heart surgery, when we do a CABG, we have to open the pericardium itself to get to the heart, and you're not required to close the pericardium itself after you're done. The heart won't go anywhere. It won't fall out of the chest or anything like that. So it's not required to close that. So whenever we do the evacuation of the fluid with a pericardial window, we do not close that space. We just leave the drain in, and whenever we're satisfied with the amount of drainage, we remove the drain itself. So it won't do any harm, actually. So after a vein or artery is harvested for bypass, is the remaining tissue deprived of blood? That's a good question. So in terms of veins in the legs, there is quite a significant network of veins that bring blood back to the heart. Arteries deliver good blood to the tissues, and veins bring blood back to the heart after it's used by the tissues. So there are a ton of different veins that will compensate for us taking out the saphenous vein. So the patient will notice a little bit of leg swelling after it is taken out, but that should only last for a week or so. And we usually place an ACE bandage around the leg to help with that swelling. So in terms of the vein, there will be no problem with taking that out. With the artery itself, there are collateral arteries that supply that tissue. If you're talking about the left internal mammary artery, the chest wall will still get collateral circulation from smaller arteries to supply blood to the chest. So that won't be a problem. And in terms of the radial artery, the ulnar artery is left, and that'll provide blood flow to the hand itself. You feel as a PA that you see a greater variety of things or cases in comparison to the surgeon. I feel like in a given day, your responsibilities can be more dynamic and fluid, where you may be starting out your day doing a cardiac surgery, and then in the afternoon, you're doing a thoracic surgery. So you might see more than one thing in a given day. However, as a surgeon, you do see everything as well. Our cardiac surgeons work alongside the thoracic surgeons if they need help with from their expertise. They'll combine, and the surgeons will work together as well. So I think that we equally see all the cases. For someone who wants to go into CT surgery, what skills do you think I should start developing? I think the biggest thing you should do, and if you're interested in any type of surgery, is start learning anatomy. Anatomy is the most important thing because as you technically do the procedure, you don't want to be second guessing what tissues you're touching or removing or familiar with. So the anatomy needs to be the sound, the solid backbone of your knowledge. Then as you start to get exposed to rotations and things like that, it's always good to learn how to practice knot tying at home, and maybe ask if you can have some sutures and needle holders and stuff like that, and start learning how to suture at home as well. It can be like a pillowcase or anything. Just get used to having things in your hands. Does resting the heart for too long for the heart-lung machine cause heart tissue to die from lack of blood flow? It's a good question. So certainly the shorter amount of time that you're on the heart-lung machine, the better. Even though we are perfusing all the tissues, there is a inflammatory response that comes from being on the heart-lung machine. So the quickest you can get on and off the machine, the better. You can develop problems with kidney failure and end organ perfusion if you're on it too long. So there is certainly a time where you could say you're on it for too long. For coronary bypass grafting, do you tend to harvest the internal mammary artery, or is that the tending? And are you in charge of the cardiopulmonary bypass machine? So the first part of that question, for most, there are instances at some practices where the PA may take the left internal mammary artery, but in my experience, I've never worked in a setting like that. Typically, it's the surgeon that harvests the internal mammary artery while the PA is taking conduit from the legs or the arm for the rest of it. And then in terms of being in charge of the cardiopulmonary bypass machine, that's actually a whole nother profession, and they're called perfusionists, which is also another graduate school. They learn how to operate the heart-lung machine as well as other cardiac assist devices. So in the operating room itself for a heart surgery, there are quite a number of people. So there's the patient, there's an anesthesiologist who puts the patient to sleep. There's the surgeon that does the surgery along with the physician assistant. There's a scrub tech who is there to hand us the instruments that we need and provide supplies that we need for the case. There's at least one circulating nurse who will, she is not sterilely scrubbed into the case, but she is circulating in the room, opening different supplies that we may need and communicating to the ICU or to family about how the case is going. And then there's the perfusionist, usually two perfusionists will operate the heart-lung machine. So that's the success of a patient in heart surgery is a big team approach. It's not just one person. How do you know which vein or artery to use? So every surgery, we look at the what is needed. So in terms of a question before, if we need to do a cabbage times 1, 2, 3, etc. Almost always we bypass the artery on the front of the chest, the left anterior descending. We use the artery from under the chest wall, the lima. And then the remaining blockages, we either use artery from the arm or vein from the leg. How do you do a specific CT surgery clinical and PA school? And did I find a residency? So in PA school, if you have the opportunity through your program, there are CT surgery, there are many different CT surgery programs, and you can just identify who the program leader is and email them or call them and see if they take students. At Lenox Hill Hospital, we have affiliations with a couple different PA schools, so we frequently have students rotating through our program. And then I did not do a residency. I have some coworkers that did do a residency, and there are several surgical residencies as well as specific cardiac surgery residencies that are beneficial. It's just all up to what you think you would do, what interests you the most. what do you want to do? Do you think you need a little more training, or do you feel comfortable off of the rotations that you had and you just want to jump into the program with a strong supporting service and learn that way? Or do you want to spend an extra year with a residency program to learn in a more controlled environment? I think both are reasonable. It's all, I think, just what is best for the you at that time in your life.
Hey, Aaron.
Hey,
I think we're going to stop you here because it's getting close to 11, but thank you so much for presenting and joining us today.
all right. Thank you for having me. And then I have my email shared, so if anyone has any questions, feel free to reach out.
Sounds good. Have a good day.
Thank you as well.